direction of the plaque. Obviously, as I'm sure you can imagine, that can be somewhat painful, and it prevents the blood from flowing as it normally would flow. So we also, there's multiple studies out there, multiple things in the literature, in animal models and human models, that say that stem cells are undifferentiated cells that can differentiate into specialized cells. They promote vasculogenesis, they promote wound healing, they not only improve the blood vessels that are present, but they also create new blood vessels. There are lots of different places where you can get stem cells, and there is some debate in the literature about this, which, depending on how much time we have afterwards, we can talk about. There's placental-derived stem cells, which is what I typically have been using. These can come from the amniotic side, which is the baby side, or the chorionic side, which is the mommy side. The chorionic side stem cells are the ones that we used in this study. There's adipose-derived stem cells, which there are lots of people trying lots of things with adipose-derived stem cells at this point, which are, if you imagine, when we eat a lot of food, we can get fatter. So there's little vascular progenitor stem cells that live in the fat to allow us to grow more blood vessels to accommodate our fat. There's bone marrow stem cells, there's embryonic stem cells, nobody's really using those anymore. And then there's one article published about a year ago now saying that they're even getting stem cells from the skin now. So the hypothesis was that if we inject these stem cells into Peyronies plaques and into the corpora, that we can hopefully treat Peyronies disease. And fortunately, this has been done a couple of times by my predecessors in rats with some improvement. So our objective was to evaluate the feasibility and effects of intracavernosal and intratunical injections of placental matrix-derived mesenchymal stem cells for the treatment of Peyronies disease. When I say placental matrix, it's because these stem cells are on an extracellular scaffold of collagen as well, and so it's called a placental matrix. We obtained IRB approval, we obtained informed consent, we used the penile Doppler to look at our peak systolic velocities. Penile ultrasound was used to count the number of plaques we have and the size of plaques, and then we used a protractor to look at angles. On a separate visit from the penile injection, we then took a 1 cc vial of mesenchymal stem cells, of these placental mesenchymal stem cells, diluted it to have enough fluid to inject around these plaques, and into the corpora, used 2 cc's to inject around the plaques, and then use the other half a cc to inject into each corpora cavernosum. We then looked at these patients at 6 weeks, 3 months, and 6 months for this study. And again, just to point out our study measures, we looked at a bunch of other things like IEAF scores, stretch penile length, penile width, but the main things that we're talking about here are going to be the peak systolic velocity, the size of the plaques, the number of plaques, and the angle of the curvature. We can talk about the other stuff too in questions and stuff if you want. So this is my numbers from my initial peak systolic velocity with Trimix, and what we did was we gave 0.2 cc's of Trimix, the exact same Trimix, then waited 20 minutes and checked to try to standardize where we were in this process before we got our peak systolic velocities. And you see these are the initial peak systolic velocities for our 5 patients. At 6 weeks, every patient had improvement. And then at 3 months, only 3 patients were willing to have Trimix re-injected into their penis, but the improvement was so much that we had statistical significance there. As far as the plaques go, we measured out the size of the plaques. As I'm sure most of you guys know, when you feel a Peyronies patient's penis, although the plaque might feel much bigger on ultrasound, the actual plaque itself, I believe it's probably surrounded by a bunch of fibrotic tissue because the plaque itself always looks on ultrasound smaller than it feels. But the plaques literally practically disappeared, and they did disappear. In total, we had 10 plaques. 7 of the plaques, 100% disappeared. We had, I think the smallest one had a reduction of 46%. When we looked at angles of the penis, one of the patients had no curvature. To begin with, he just had a plaque, so that he was a nun. We had one patient who, couple actually whose angles decreased 100%, and a couple that decreased somewhat less, 43% for one of them and 43% for the other one. All of the patients were happy they participated in the study. Not all of them were happy with their penis. So for instance, one of them went on to develop, to go on to, patient number one actually went on to have a 16-dot application. He's, a somewhat crazy guy, as Raphael can attest to, because I sent him to him. Patient number two refused to have his post-6-week injection because, interesting enough, with the same 0.2 Cs of trimix, he developed a priapism on a 6-week injection. So the question becomes, well, why didn't he have the priapism the first time? It's probably because now he had improved blood flow, I would like to think, in his penis on the 6-week mark, causing him to now have a priapism. He also went on to have a very small plaque. I put in the dimensions because, that's how we were measuring these plaques. We were trying to be very, very particular, and when we come up with the sizes of the plaques, we were going out to the 100th of a centimeter. And patient number one, like I said, went on to have a 16-dot. This was patient number 5, and we have plaques we measured, we have peaks of stop velocities, and we have angles. Now I apologize because I told my ultrasound techs my one ultrasound tech doing this, to take pictures of the penis, and I thought it was fairly obvious that you take a picture in the same way you took the first picture. But she was very bad at taking pictures of erect penises. And so I'm working on that in the future. But the plaque sizes got smaller, the peaks of stop velocities got higher, and the penises got straighter. So in conclusion, I believe this is the first study to talk about injecting stem cells into humans for Peyronies disease. The sample size is obviously very small, it's 5 patients, but the results are so promising that it really, there's statistically significant improvement in blood flow that's sustained, and there's significant plaque reduction and curvature reduction. I really do believe that stem cell medicine, biological medicine, is going to be the pathway for the future for erectile dysfunction and Peyronies disease. That's it. Thanks, guys.
We have time for some questions. Dr. Cotto.
What would be your criteria to try using the injection according to the plaque or curvature of the penis? That's number one. And second, how much 3 weeks you give it for both stagnation?
How much? So the second question I heard, which is how much trimix, I gave 0.2 cc's of trimix. That's it. But it's a strong trimix. It's my strong dose.
And we'll take Dr. Cotto's question just because it may overlap with Dr. Cotto's question.
Yeah, I just wanted to say I'm impressed. It was very interesting, very, very nice. I appreciate your enthusiasm, and I think we're all enthusiastic based on this, but we have to just keep it in, in scientific, on the scientific basis. It's a nice case series we got here. And it's a hypothesis-generating series, basically. So I don't know if we can develop any real tremendous conclusions from this, except for the fact that we've had some marvelous results. I think it definitely warrants a little bit of further work. This kind of disputes a little bit about what Dr. Liu was saying a couple of days ago. And I think that, Zahalsky series with Peyronies is interesting. They use human stem cells in animals, but they did it at the time of the insult to the rat. They didn't do it after the plaque was already organized and formed. Right. So I just wonder if this is a little bit different, and that's why we're getting a little bit different result in these humans.
And I didn't look at whether or not these people are active or passive phase Peyronies. Some of these people were in the active phase, and I don't know if that makes a difference. I'm sure it does. But I didn't go out and recruit patients. These were patients in my practice that came in that were willing to have somebody else's stem cells injected into their penis. I do. I believe that there's a lot of work that needs to be done. I need help. I think that the concept of these meetings is to say, look at what I'm doing. Hopefully, on a more global scale, we can advance this field. But when you talk about mesenchymal stem cells, for instance, this company won't quantify how many stem cells are in each of their injections. The product I'm using actually is pulled from the market, the product that was used here. And I don't know why, I don't know, but it was called a mesenchymal, a chorionic mesenchymal stem cell product, So now in my office, for people that want it, I'm using amniotic. But it's, do you get the same results with one versus the other? You don't know. And that's where part of this problem is as well. Like, what growth, is it the stem cells or is it the growth factors? Because it's all mixed with amniotic fluid, and there's lots of growth factors in that amniotic fluid. And again, I don't think we have those answers, and I think that needs to be further defined, but at the same time, we're dealing with the desperate population here. These people are really frustrated with their penises, and the concept that we have something out there that we don't really know how it works, but we see that it's working. The real question is it worth, is it our responsibility to be telling them and offering it to our patients?
We're going to go ahead and conclude at this point and ask for the next speaker to start working their way up. We thank Dr. Z here. Excellent message, and it actually goes against the grain, kind of like what Dr. Cava said, because a lot of people were on the stem cell wagon, if you will, almost a decade ago, and kind of switched to other modalities, and to see something presented here is actually of interest, because there is a lot of attention that's warranted to further investigate all the lines in stem cell research still for the phallus, if you will, because you could see there were changes to erectile function, so you're not really addressing just plaque or the tunica abyggenia. So very good, thank you. Thanks.